session, which it will be uploaded to the Healthier Together website after for sharing. So welcome everybody to the Healthier Together Lunch and Learn this afternoon session with a focus on children's sleep. It's going to be delivered by Dr Liz McLellan from Great North Children's Hospital, and I will just do a bit of an introduction. My name's Laura Cassidy from the Child Health and Wellbeing Network for North East North Cumbria Integrated Care Board, and I lead on the Healthier Together website and mobile app. If you could just put it on to the next slide, please, Liz. Just a bit of context and background from a network perspective. Very much the work that we do is around improving health outcomes for children and young people across the region, very much driven by obviously those health inequalities, and you can see some of the figures and statistics there, which I'm sure you'll all be familiar with, and very much working within the challenges that we face across the region. Healthier Together is very much driven by high rates of A&E attendances. We have the highest rates in the country for children aged 0 to 4, and it's very much about trying to ensure that parents and carers have access to consistent health information and advice. As part of our network role, we very much focus on overcoming some of those challenges to improve the health outcomes, and it's very much about collaborative approaches, working with wider partners, using data to target high prevalence areas, and very much that system-wide engagement. If you go to the next slide. So the network's foundations and principles is very much we have a shared vision that we believe all children and young people should be given the opportunity to flourish and reach their full potential by organisations working together as a network. We have over 2,000 members, and very much about sharing models of good practice, testing and driving work and innovation forward. You can see on the right there, we have our priority wheel. Central to that is children, young people and families and their youth voice. So we work in partnership with our youth board, who very much support alongside our strategic oversight group in reviewing and the decisions around work that we do as a network. You can see around the outside those priorities, which I'm sure will be very familiar to everybody, around kind of childhood illness, mental health, poverty, additional needs and vulnerability, inequalities and access, that strong start in life, health promotion. As a result of COVID, we went back out to the system and asked if there was anything missing, and family support was very much up there of one of the priorities that people identified, and I'm sure you'll agree that as we've came out of COVID, family support has been very much that additional requirement of all settings, whether that's an education setting or within a health context. I'm going to stop there and I'm going to hand over to Liz. Can I just remind everybody to please make sure that your microphones are on silent?
Thanks, Laura. So like Laura said, my name's Liz McLellan. I am a consultant paediatrician at the Great North Children's Hospital. And within that, I have a specialist interest both in paediatric respiratory medicine and also sleep. I work alongside both teams as part of the tertiary provision for these services. So, first question that I always ask myself is why me and why today? Well, I did a respiratory spin as part of my latter stages of my paediatric training. I work as part of the sleep MDT, but actually it turns out it's a personal obsession. And actually these are all pictures of my children. And I clearly am obsessed with sleep because when I look at my camera roll and put sleep in, actually I've got a lot of pictures of them asleep. And a lot of this was born out of the fact that actually one of my children really didn't sleep when she was a younger infant. She does now, but she definitely didn't. And I was very much that parent who was in the throes of sleep deprivation. So I always like to think about what actually is sleep. So sleep is superficially, it's a passive process. But actually, when we dive down into it and we think about it, it's a highly active, complex state. So there's different definitions that are out there for this. My favourite one is actually it's a reversible neurobehavioural state of relative perceptual disengagement from and unresponsiveness to the environment. So sleep is typically, in humans, accompanied by postural recumbrance, so lying down, behavioural quiescence and closed eyes. And actually that probably fits with most of what we do tend to see. It's a naturally recurring state of mind, which is characterized by altered consciousness, relatively inhibited sensory activity. Lots of things shut down and slow down. We have inhibition of nearly all of our voluntary muscles during this, and actually we have a reduced interaction with our surroundings. So sleep is governed by the suprachiasmatic nucleus, which is here, this gland at the back of the brain. It is governed by the prevention of the production of melatonin by the pineal gland, and these are all things that can inhibit our sleep. We think about melatonin as being the sleep hormone. So the thing that we think about for children and thinking about, have they got sufficient melatonin? What are we doing that's affecting their melatonin production? And for all of us, when they've studied this, our peak melatonin is increasing in terms of its concentration within the evening. The levels get to their maximum in the middle of the night, so around between 2 and 4 a.m. And then they quickly drop into the morning and your melatonin levels fall again. And then they'll start this cycle, and it repeats again and again as part of this circadian rhythm of sleep and sleep induction of hormone. So if we think about it in terms of the recommendations amount of sleep by age, now these are variable things. These are different for each particular child and adult, but actually if we think about it from context of a newborn, so they need between 14 to 17 hours of sleep, and by the time they reach the end of teenagehood, so around the age of 17, you need between 8 to 10 hours of sleep. But actually, most adults, and that's because we have data on adults, but most adults in the UK are chronically sleep deprived. So for that, that's missing around 1 hour every night would mean that you're missing one entire night's sleep per week. And I think actually we don't think about sleep enough. And I think with the advent of technology and the differences in terms of the demands on our time, we probably need to be more conscious about sleep and about thinking about it a little bit more. I quite like this graph at the top. This was data from the Sleep Project, which was done out of Durham and Professor Ball. And this is looking at the amount of sleep that infants need. So if we look at the beginning, this is newborns, and it's showing that there is a median. So for the median is around 16, but there's a variance between 20 hours and 13 hours. And actually that's then changing as these children are getting older. And again, I just think it's useful to be reminded how much sleep we think that people do need out there. But why is it important? Well, the NHS Digital 2021 follow-up report survey looked at sleep and found that sleep issues are increasing. So on that survey, there was about a third of children between the age of 6 to 10, so that 28% of children had said that they had had trouble sleeping on 3 or more nights in the previous week. Actually, the data is there that actually it's having a huge impact on lots of different children. These problems that they talked about was problems getting to sleep, problems with them waking in the night, or actually waking early in the early hours of the morning are really quite common and affecting about 38% of children by the time they get to between 11 and 16 years old. And sleep has an impact on your growth and development. It has an impact on your attention and your short-term memory. It has an impact on consolidation of long-term memory and decision-making and reasoning. And these are all key things that children need to be doing as they're navigating their childhood, as they're growing, as they're developing, and as they're reaching their developmental milestones. It also has a huge role in almost every system of the body. So thinking about from an immunodeficiency point of view, while you are asleep, your immune system is producing antibodies and cytokines, and these substances will help you combat the bacteria and viruses that are coming into the body. These cytokines also help you to sleep. So actually, if you're unwell and you're going to sleep, actually that's giving your immune system more efficiency to defend your body against these illnesses, these bacteria and these viruses. If you're not getting enough sleep, your body might not be able to build up its antibody and cytokine levels, and it might actually take children longer to recover from illness. From a cardiovascular point of view, when you are asleep and in your non-REM sleep, both your heart rate and your blood pressure are going to go down. And actually, the heart rate and blood pressure will gradually increase back up. And if you're not getting enough sleep, then actually these children are found to have higher heart rates, higher blood pressures, and actually they can go on to have problems with their heart. Hormone imbalances. So your growth hormone, your thyroid hormones, your cortisols, all of these levels are helped during your sleep. So actually, if you are not sleeping well, then you may be more likely to have increased levels of your ghrelin, and also your gut hormones, and these can be increase. So if you have insufficient food sleep, then your food intake will probably go up the next day. From a pain threshold point of view, sleep helps with recovery from pain. We know that for children who are in hospital, actually poor sleep means that they experience pain in a different way and are more likely to require increased analgesia. We've talked about hormone imbalances, and that relates to obesity, but also to diabetes. And mental health disorders are also at increased risk of poor sleep. So why is it important and why do we need to think about it? Well, I've already told you that the impact of poor sleep is increasing and recognised by more and more children. But actually, the impact of the sleep disturbance is not only felt by the child, but potentially also by their carers and their whole family. We know that there are studies that have shown that sleep deprivation means that adults are at more risk of accidents. It's a risk factor for depression. It makes it difficult for them to make decisions. And these decisions, particularly from my point of view for inpatients, these might be where we're asking parents to make critical decisions about their children. And we really need to get those decisions right. It can also alter the parent's immune function and also is a risk factor for obesity due to the increased insulin sensitivity. So what do we need to do? We need to do the basics, and we need to do the basics well. We need to think about our sleep history and whether that's using screening tools to help you think about the different parts that we need to think about. It's thinking about the red flags. But it's also recognizing that actually healthy sleep duration is variable and different children will have different needs. The most important thing that we can do well for all children, whether they have sleep problems or no sleep problems, is thinking about behavioural bedtime interventions. So thinking about doing those basics well for all families from a routine point of view, but also to help people get the most benefit and the better nice sleep. And planning intervention is important. There's no point doing an intervention at a time when things are really stressful and when people are really struggling. Actually, they need to have the support to make that decision to do that intervention and to do it at the right time for them and for their child. So I thought it might be useful to have a think about a few different cases, people that I have seen, whether that's in my outpatient clinics or in my acute admissions via A&E or our inpatients on the wards. So I'm just going to get you to have a little think for a few minutes. So case one. A 4-year-old boy who's recently started in reception at school. School have noticed that he's falling asleep in the afternoon and they've raised this with his parents and mum's brought him in for a review. What do we need to think about? So just have a little think about what you might want to know about this and how you might navigate this. So from my point of view, we often use the BEARS sleep screening, and this is developmentally appropriate trigger questions. It was developed in 2005, and it's been validated to be a useful screening tool, both for primary and secondary care when asking about sleep issues. It breaks it down into these 5 different areas and suggests appropriate developmentally trigger questions that for the different age ranges that you can address either towards the child or their carer. So the B, thinking about bedtime problems. Is the child having any problems going to bed? Do they have any problems falling asleep at bedtime? What's going on at that period of time? Then thinking from E, excessive daytime sleepiness. Are they overtired? Are they falling asleep in the day? Do they fall asleep just at the drop of a hat without any warning? Do they fall asleep if they start laughing? Thinking about are there other conditions that may be causing excessive daytime sleepiness? Thinking about awakenings during the night. Do they wake up during the night? Are they sleepwalking? Are they sleep talking? Are they having nightmares? Do they have trouble going back to sleep? And again, it's about pointing out and thinking about, is there anything else that's going on? Thinking about regularity and duration of sleep. One of the most important things is to have a regular routine because that helps your circadian rhythm and your bedtime clock. What time is the child going to bed and what time are they getting up on school days or weekends? Is there much difference in this? Do you think they're getting enough sleep? Does the child think that they're getting enough sleep? And then thinking about snoring, do they breathe noisily at nighttime? Do they have any pauses in their breathing? Is there anything that's suggestive of obstructive sleep apnea? And this screening tool, like I said, has been validated, but it's also a really useful prompt to just think about the different aspects of sleep that we do need to think about. So if we think about our case from a bear's point of view, so it was a fight to get the child to go to bed. He would often make disruptions and not be ready to settle down in bed and want to be coming downstairs repeatedly to see what was going on. From an E point of view, he was tired and grumpy in the mornings and he would still have a nap on the weekends. From an A point of view, nothing had been raised. Bedtime was around 8:30 p.m. and he was getting up at 6:30 p.m. but still being a bit tired in the morning, but having about 10 hours sleep. On a weekend, he would tend to go to bed a little bit later, and they felt that he was quiet when he was asleep and no issues from an apnea and snoring point of view. So actually, it's really important to then think about this from a bedtime and a nighttime behaviour point of view. And actually, I find that going back to the same 5 areas is really important for this. So thinking about a bedtime routine, does the child know the signals, the cues for when they're going to bed? Do you do the same thing every night? Do they have a bath on a Monday? Do they have a bath every night? These sorts of things can be really helpful to the child to signify that it's bedtime, it's time to settle down, it's time to get ready to go to bed and have that calming experience for them. Thinking about the environment's really important. I often will ask children or teenagers, actually, do you like your bedroom? If you could change one thing, what would it be? Sometimes actually they might come up with really appropriate things of, I don't like the amount of noise that there is next to my bed in my bedroom. It might be related to the dark. So some children like a nightlight, some children want it totally dark, other children want the door cracked open. Thinking about exercise. So exercise is great. It does tire children and people out, but actually doing exercise too close to bedtime can actually be inhibitory for helping you go off to sleep. Again, thinking about food and drink. So having an adequate break between eating your evening meal and going to bed can be really helpful to avoid that digestion and those difficulties that can sometimes be experienced if you eat a large meal and then try to go to sleep. And thinking about self-settling. Has this child always been put to bed and have someone there with them? Have they learned to settle themselves down? Have they learned to put themselves to sleep? And actually, this is really important when it comes to the middle of the night wakenings, actually making sure that the child has the skills themselves to be able to go to sleep. And if they do slightly wake up, which we all do, or do lighten in their sleep, actually, can they go back to sleep on their own and settle themselves down? Behavioural pattern insomnia is probably one of the commonest presentation, and this can include bedtime refusal and resistance. It can include delayed sleep onset, so actually that period of time when the child goes to bed until they actually fall asleep. And there may well be that we see prolonged night awakenings, which require parental intervention, which just adds to that general tiredness and burden but that poor sleep has on the whole family. It's often related to poor routine and not continuing with that routine no matter what, and it can be related to underlying health conditions. We see it in our young people that are admitted to hospital. They're in hospital, they have interventions in terms of observations or medications that are late at night that might disturb them, that might prevent them going to sleep. And actually empowering parents and young people to say, no, this is my bedtime routine, and trying to stick to it is really important. And the first line treatment for all of this is behavioural intervention. So I've talked about these interventions that can be put in. So routine really helps from a circadian rhythm point of view. It helps with the secretion of melatonin. It helps them to settle and helps them to unwind. One of the things that we always try to suggest is actually getting some daylight, particularly in the mornings. So for those teenagers who don't want to get out of bed, even something as simple as opening the curtains and getting some natural daylight can help them and help their melatonin production later on in the evening. Even just sitting outside and getting some fresh air, whether that's for grown-ups actually having a cup of tea outside in the morning, again, that can be really helpful. We always try to recommend for our young people, even if they're not accessing school at these periods of time, actually just get outside and get a fresh air, walk for 5 minutes around the block, try and get that done in order to help you when it comes to bedtime. Routine helps children to settle, it helps them to unwind, and most children like the regularity of knowing what's going to happen next. Knowing what those expectations are can be really helpful for all members of the family. Thinking about environment and technology, so I've talked about the noise levels. Thinking about a bed, is your bed comfy? Do you like your bed? Actually can be really important, because it might be something really simple that the child doesn't like that's making them not want to go to bed. Do they not like it because it's under the window? Can you perhaps even make a simple adjustment, and that might make a big difference. Thinking about the temperature, so some of us like windows open at night time, some people like to be really cozy and snug, so again making sure that it's comfortable. Technology and electronic devices is a huge thing. It's become more of an issue over the years, where most of us have, I'm talking about from an adult point of view, but it's certainly becoming more prevalent for children, but mobile phones. There might be iPads that are in the bedroom, there might be computers for computer games, and there may just be normal computers. There's so much more electronic devices around. For a while, we thought that actually it was the light that was coming out the electronic devices that was a problem. And while we still think that that is an issue, actually we realise it's probably not as much of an issue as we thought it was. One of the greatest things from the electronic devices, though, is actually the stimulation to your brain and to your mind. So playing on a computer video game, getting your heart rate up during that, or playing something that's particularly stimulating to the brain, well, is more likely to keep someone awake at night. And we know that there's links to later sleep onset and sleep latency. It's been shown that for teenagers where there are strict bedtimes and strict parental controls over telephones, actually these children tend to sleep better. And a lot of that is probably the telephones or the mobile devices being taken away earlier. So actually the children then aren't doom scrolling, going through their social media, going through other things, watching YouTube shorts, which are keeping them awake at night. And actually, there's good evidence that removing technology from those points of view is hugely important. I've already talked about exercise, particularly in the mornings, avoiding that too close to bedtime. And also it has been shown that exercise during the daytime will make sleep deeper, but also you're more likely to have fewer nighttime wakenings. Avoiding caffeine is particularly important when talking to our teenagers, particularly thinking about energy drinks that are now more available, and actually often they don't appreciate the impact that that might have on their sleep. I've already talked about self-settling, whether that's making sure that they're gently being returned to bed, and trying to be consistent in a response across the caregivers can be really helpful. We need to think about anxiety and worries. So what is it that the child's getting up for? Actually trying to explore that can be really useful. There are resources available. So the Healthier Together webpage has got sleep and sleep advice pages, which is broken down into infants, but also to younger children and to older children. And there's leaflets that are available on there that can be shared with families, with some useful hints and tricks all about the routine, the food and drink, and the other parts of it. The Hiller and Gradisar book, Helping Your Child with Sleep Problems, the self-help guide, has actually been shown to be really helpful, and we recommend that to a lot of our families that we see in clinic. A way of working through it to see what can you do to make things a bit better. I think the other thing that I hadn't really appreciated until recently is actually the impact of bed poverty. So this is where a young person doesn't have their own bed to sleep in. So many youngsters sleep either on mattresses on the floor, they might sleep on sofas, some young people will be sleeping directly on the carpet, or they may be sharing beds with their family members. In 2017, Buttle UK did a household survey about this, and they found out that approximately 400,000 children in the UK didn't have their own bed to sleep in. So this related to about 27% of children in low-income families. And this problem is growing. Bed poverty has been discussed and it's been debated in Parliament, and they are planning to create a national sleep strategy to try and help end child bed poverty. We know that a lack of bed is more likely to relate to poor sleep, and that has a direct effect on those things that I've covered before. There are several charities in the Northeast that do work to help support families. So these are some ones that I have found out about. And actually, simple things. So at my children's school, we put a message out about bed poverty and with links to some of these charities. And actually, families did approach them, families that weren't aware that there were people that could help them and support them with getting a bed for their children and hopefully getting a better night's sleep. So, thinking about case 2. So this is a 7-year-old boy who's snoring, who's tired and grumpy in the morning, whose family say, actually, he's really hard work and really grumpy. I think he's a teenager already. What do you want to know? What do you want to think about for him? So thinking about snoring. So snoring is actually really common, and it is essentially repeated episodes of the upper airway which is becoming obstructed during sleep, and it causes disruption to both the normal breathing and to the normal sleep patterns. We know that there is primary snoring where you just have snoring but without any other abnormal effects on your ventilation or sleep disturbance. And then what we need to worry about is obstructive sleep apnea. And having a think about this is actually, do we need to do something about this? In obstructive sleep apnea, children will have abnormal ventilation. So we might see abnormalities in their oxygen levels, in their carbon dioxide, their waste gas being raised, and we can also see sleep disruption. We need to think about nocturnal symptoms. So does the child just snore? Are they just noisy? Do they mouth breathe? Are there witness pauses in their breathing? Are they snorting or gasping during sleep? Is there any restless sleep that's going on? And what effect does it have? So you can see that children can sometimes get themselves into what we call like a banana base position where they're with their head back with their mouth wide open. Can you see that their chest and their tummy are in direct opposite to each other, not in that normal relaxed sleeping pattern? We can see other issues that this may have. So children can present with nocturnal enuresis, so wetting overnight, particularly where they've been dry previously. In other cases, we can actually see families do report that the children appear blue around the lips. From a daytime symptom point of view, we're thinking about, are they unrefreshed in the morning? Are they tired? Are they grumpy? Are they difficult to get up in the morning? Do they complain about morning headaches, and do they complain about daytime sleepiness? And these are things that we may want to have a look at in a bit more detail. There's lots of risk factors for snoring for obstructive sleep apnea. So actually the sleep state that you are in, so if you're in the more active versus the more relaxed sleep state, then that can predispose to it. If there's any issues with airway narrowing, so is there actually just normal anatomical variation where some children may have a slightly narrower airway compared to other things, or is there tissue within that airway? So have they got enlarged adenoids or tonsils, or have they got adipose tissue? Are they obese? Do they have problems with the amount of tissue around the airway, and that's compressing on it? There can also be rarer things like muscular, so storage disorders that can cause this. Thinking about it from an abnormal muscle tone, so we often see in our young people who have cerebral palsy or trisomy 21, they're more likely to present with obstructive sleep apnea, and we keep an eye on it in those young people. So we're going to want to have a look at these children, look to see, have they got large tonsils? Have they got any evidence of their nose being too small? Are they mouth breathing just during the daytime? Are they obese, or are they having symptoms of failure to thrive because actually they're struggling to gain weight because they're using all their calories at nighttime to help with their effort of breathing? And again, we look at tone and muscle weakness. So investigations that we might want to think about doing for these young people, the first one that we would tend to do, and the kind of basic one, is an overnight oximetry. And this can be enough data to give us the information that we need to refer through to the ear, nose and throat surgeons. So with this, we're looking at the oxygen levels on the top, the SpO2, and the pulse, the heart rate at the bottom, with the time axis along the very bottom. From an oxygen point of view, we're looking to see, are there any clusters of desaturations? and are they how far down are they going, and this can help us work out how quickly we need these children to be seen and potentially have their adenoids and tonsils out if that's found to be an issue. If you have a normal oximetry, then that's really reassuring. We would tend to just observe them. We might not need to do anything else. Sometimes we do need to repeat oximetries if there are ongoing symptoms, but it can be enough just to reassure a family that yes, your child is snoring, but no, it's not having a longer term impact. We don't need to do anything else about it at this point in time. In some young people, we move on to do a sleep study. So this would be where we're looking at the oximetry and there are potentially significant desaturations seen. And on this oximetry, you can see with the purple bars, this is periods where the child is having what we call an apnea, where they are not having as effective breathing and they are not their respiratory and their abdomen are not working in conjunction to each other. So they're having pauses in these breathing, and parents might report this with gasps or with snorts or waking up after these. We can often see these in clusters. And again, this just helps us work out, do we need to do something about it? Does that need to be intervention from a surgical point of view, or do we need to support them with some overnight ventilation? In the case of our child, he went forward and had an adenoid tonsillectomy, and then we repeated the oximetry around 6 weeks later to make sure that that had recovered, and actually there wasn't anything else ongoing. We need to make sure that we do this in order to think about ongoing issues and address any other potential causes. If we put it all down to adenoids and tonsils, then actually we might miss those young people that are having issues because either they're overweight, or there might be some underlying muscular disorders that we're missing about. Sometimes these young people do need to be re-referred back into the ear, nose and throat or the respiratory clinic for a further assessment.
Liz, before we go on, we've just got a question in the chat.
Oh, sorry.
It's okay. What level of desaturation is normal and what is worrying?
So normally we wouldn't see any desaturations. So you might see the odd little desaturation within the 90s. If we see them down to the 80s on 3 or more occasions, that's where we would say actually there's some sleep disordered breathing going on here. Again, it depends a little bit, what do their baseline saturations look at? But the key thing is 3 or more desaturations to the 80s, we'd say you've got mild sleep disordered breathing. So there's a scale that we use to then work out, are they mild, moderate or severe? In some people, I've seen them down to the 60s, so that would obviously be a severe one. It's looking at how frequently are they happening and then kind of strategizing what do we need to do. So all the oximetries that are done by the physiology team within the Children's Hospital are looked at by members of the respiratory team, and we then will write to whoever's requested them and then make a suggestion for a plan if we get lots of referrals from our ear, nose and throat team, and it would be kind of guiding them, actually you need to do something about this one on a soon to urgent basis, and we try and make those kind of statements when we're looking at them. I hope that helps a little bit. So moving on to case 3. So case 3, a 5-week-old baby with faltering growth and noisy breathing. So again, just thinking about what do you want to know for this baby? So they're seen at the GP, who asks about the noise. The noise is an expiratory noise, so it says the child is breathing out. It's a high-pitched noise, which has been there for a long time, but it's always worse when the baby's asleep. The baby is not gaining weight, so there's a feeding plan, but they're still not gaining weight appropriately, and they've now noticed that they're having pauses in their breathing. So this child was referred up and seen by the respiratory team in our children's A&E, and a decision was made that actually there's some squeakiness, and you could see that the weight had just faltered when we reviewed the red book, and we were worried about the fact that they were now having these pauses. They were admitted overnight and we did an overnight oximetry. So if we look at this overnight oximetry, we can see that the baseline saturations are sitting in the mid to low 90s, but there are clusters where, so at midnight, they're going down to 85%. At 1 o'clock in the morning, there's again a big cluster where they're going down to 85%. And then at around 2:45 in the morning, they're going down to the 70s. And then after that period, we can see that the oxygen levels, the average is just tailing off and sitting within the 80s at that point in time. So with this oximetry, they were seen by the respiratory team again the next day, and our ear, nose and throat team were asked to review them as well. And they are able to do what's called a flexible nasoendoscopy. So this is where they come, they have a look with a camera, and this is the view that you can see down. And they're looking at the airway to see, is there a problem with the airway? Does this child have a normal larynx? Does this child make any difference when we put a jaw thrust on? And what's going on? Do they have any obstruction and crowding? And this child had laryngomalacia, so they had a floppy larynx. And a decision was made for what do we need to do about this. So actually, some of these young people do need surgery to help treat their laryngomalacia, but actually the child in this case had some feeding support. So the speech and language team supported them with how to feed this infant with kind of positioning point of view. And they were tried with high flow nasal cannula, so in air to help provide them with some flow to help with their breathing, and their oximetry improved with this. They then had a period of stability while we monitored them from a feeding and a growing point of view to make sure that they were still stable. And this child was actually discharged home with high flow and had ongoing respiratory input. So they were seen regularly in our respiratory paediatric clinic to make sure that they were doing well. This child didn't need surgery and remained on the high flow until they were about 6 months old, and then they were able to actually come off it because actually they could support their airway. They weren't as noisy as they had previously been, and they were growing well. So they just needed that support for that initial period of time while they were an infant. So, case 4, 14-year-old girl who is tired all the time. Thinking again, what do you want to know for this case? So, thinking about this young person, what time is their bedtime? What time is their sleep time? And that can be very different. So lots of parents and young people might think that they're going to bed at 10 o'clock at night, but actually their sleep onset time might not even be until 1 o'clock in the morning, 2 o'clock in the morning. Sometimes, particularly in teenagers, they tend to be a little bit more quiet on an evening. So actually parents might not quite be as aware as to what time they're actually going to sleep. What time is this teenager getting up on the weekdays and the weekends? How much of a difference is there with this? And what's going on with their phone? And again, that's the thing that I ask them. And I ask them to be honest with me. I say that actually I use my phone in the bedroom and it can sometimes keep me awake at night. Do you find that's a problem? And often that's enough to kind of start that conversation and find out what is it that they're doing. Are they putting it down but then not going to sleep, so they're picking their phone up again? Are they scrolling through, whether that's social media or nowadays it's looking at shorts and short videos? Actually, what is it that's keeping them up with it? We got some more information. So a sleep diary is hugely helpful. It helps them think about what time are they going to bed? What time are they going to sleep? What time is their wake up? And the children can document any nocturnal any nocturnal wakenings or any issues if they get up to go to the toilet, what's going on with it. It can be really helpful for showing the families actually the differences between what's happening, but it can be a really useful measure for the families and the young people in thinking about their sleep more importantly. On the right hand side, we can see an actigraphy. So we have some actigraphs that our physiologists have. It's a kind of smartwatch-like device that monitors activity levels. It looks just like a smartwatch, but it is used to look at movement during sleep, but it's also looking at total sleep time in terms of what's their wake time. It can also be used to see how long are they going outside, and we can use that to then look at their sleep rhythms and sleep onset to see what is going on. We tend to do it for a 1 to 2 week period, and again using the daily sleep diaries at the same time to then correlate this information and to get them to think about what are they doing, what daylight are they doing, what are they doing with their time. We see teenagers, so between 17 to 16% of teenagers will present with a delayed sleep-wake phase disorder. And this is simply what it says. It's a delayed sleep pattern in relation to what is desired sleep and wake times. Teenagers often complain that they might have trouble falling asleep. They might have an inability to wake up in the morning. And when they do go to sleep, actually, they have a normal duration and quality of sleep when there is no need to go to sleep either at a certain time or to waken up at a certain time. And it's defined as being there for at least 7 days. And actually, we saw a lot of this in COVID. A lot of young people weren't needing to get up to go to school. They didn't have those pressures on their time. And actually, they just naturally shifted their bedtimes later. And this can be absolutely fine until you have the social construct of needing to get up in the morning, needing to be at school on time. In different countries, they've looked at this. They've tried to adjust their school school start times to kind of take in this natural teenage phenomenon of going to bed slightly later. We're not there with that in the UK, and at the minute, teenagers do need to go to school, and often still at that 8:30, 8:40 start time. So actually, what's really important is talking to them about what they need to do on an evening and how they can make things better. To make things better, it's about thinking about the basics, that routine, that exercise, food, environment and technology, and worries and anxiety. Making sure that they are gradually creeping that bedtime forwards and making sure that those routines and those habits are there. Particularly with teenagers, I talk about going outside and getting daylight in the morning. Particularly with them, I think about their technology use, whether that's putting their phones outside the bedroom. Having downtimes on phones can be really helpful as well for these young people. Sometimes parents and teenagers are aware of these things, but they don't really think about it. And it's only that when it becomes a problem that they then need to think about it a little bit more. And actually, that's sometimes just enough of a useful prompt to help them to get things better from a bedtime point of view. For some of these young people, we do use melatonin, and a strategically timed low dose of melatonin can be enough to regulate their sleep-wake cycle. We would tend to start it at a low dose of 2 milligrams about 1 hour prior to bedtime. So if their current sleep onset time is 2 o'clock in the morning, we'd suggest that they give it at 1 o'clock in the morning, and then they gradually bring this bedtime forward in increments. It must be done alongside sleep hygiene measures. Melatonin is not a magic drug, and it is not going to work on its own. And I always say this to families that they need to be engaged with this because they will slip back into old habits if they don't keep on with it. In some young people, we have had to do admissions to help do this, but actually that's where actually they can do this at home. They just need to be really rigid and follow that sleep hygiene measures along with it. With melatonin, we suggest that they stop it if it's not working and they have a break off it. So they need to have a break off it to see actually, do they still need the melatonin? Does it still make a difference? Could they go on to a lower dose? And hopefully we'll get them sleeping like this lovely sausage dog and enjoying a better night's sleep. We do see that with delayed sleep-wake phase disorder, these young people can slip back into it. So again, it's about reiterating to families and the young people that actually they need to keep on with it. They need to be conscious of their bedtime routine. They need to keep in mind that if things are slipping, then they just need to put those things back in place. And often once they've done it once, they can do it again. And again, it's just reminding them that it's keeping those good habits. So from a paediatric sleep point of view, we have a paediatric respiratory team at the Great North Children's Hospital. So these will see urgent referrals or organise urgent reviews. And this is often our young people who might present with noisy breathing or might present with significant obstructive sleep apnea. Sometimes these young people are seen by the ENT team first and then they come into us from there, but we work alongside them. We also see with the new complications of excessive weight service, we will also see referrals from them as well. And in fact, we're getting huge numbers of children that are coming through there where obstructive sleep apnea is being picked up by them. And then they may need ongoing support in terms of long-term ventilation. We have a sleep clinic, which is a tertiary referral clinic, which happens once a month in and this is part of an MDT team, so we have access to respiratory physiologists and further investigations from here. We work alongside our ear, nose and throat colleagues. We have access to adult neurologists who work alongside us for any abnormal movements in sleep, or any of our cataplexies and narcolepsies as well. In the south of the region, James Cook take referrals and have access to sleep studies, and they have direct involvement, and we work with them as part of the long-term ventilation team. So we run joint clinics with them, and children who are set up with home ventilation would be run jointly by both teams. There are lots of other services within paediatrics. Unfortunately, general paediatrics are not commissioned for sleep problems. So we will see, particularly if there are issues with obstructive sleep apnea, they sometimes come via us rather than through ear, nose and throat. But actually, we're not commissioned for delayed sleep phase disorder or any of the other sleep problems, and they'd need to go through to the sleep clinic. Like I said, we can do investigations. We've got lots of investigations that are at our disposal. The oximetries that we've talked about, which is a really simple machine that families can often do at home. And we do a lot of these at home. We run clinics where families come in, pick the machines up and drop them off the next day, and we can then analyse the data. We do our polysomnography, so the sleep studies that I talked about, these are all the wires that are involved with this. We measure the nasal and the mouth airflow. We look at the carbon dioxide, so the waste gas. We look at their oxygen levels with this. We look at their chest and abdominal excursion. Are they breathing in sync and in time? We have access to a camera and a microphone, which can be really helpful for us working out, is the child making noise at these points in time? Are they restless? What is going on with them? We're able to do EEG, so we can look at brainwaves. We can look at muscle use. We don't tend to do that as often in paediatric patients, but that can be done. We can look at the ECG, so what's going on from a heart rate point of view, and we can see leg movements. And like I said, all together and with the camera and the microphone, we can get a really good overview into what is happening in a child's sleep. Some of these studies we can do at home, so without all of the specific bits from here, but we can do some sleep studies on a home point of view, and we do 2 inpatient sleep studies a night in our specialised lab that we and rooms that we've got in the Children's Hospital. And these are just some evidence of what we can see and the different things that might be picked up. So the one on the right is showing sleep apnea, central sleep apnea, so where this child is having pauses in her breathing. Sorry, Joanne, did you just have your hand up?
Yeah, sorry, Dr. McLellan. I'm just I'd put in the chat a question, and I think a few other people had. I didn't know if you wanted them now or did you want them at the end?
Can I come to that at the end? Is that all right?
Yeah, absolutely.
Thank you. So resources that are available. So I've already talked about what we've got on the Healthier Together website, those sleep leaflets that can be sent. So these can be sent directly to parents and patients' mobile phones for what to do and how to think about it. There's some sleep charities that are on there as well with information about relaxation, the BEARS screening tool, and the Zaret charity, which is the one that's involved in bed poverty. There are apps that are available as well, so things like Sleepio and Headspace and guided meditation can be used from a cognitive behavioural point of view, and again just reassuring young people that actually they're doing a good job. I find it slightly counterintuitive that these are on technology, but they can be useful and they do have a role in managing children's sleep. And this is the Healthier Together webpage that you get to and all the different boxes that you can click onto. And the useful links and resources. And finally, just remembering about our own sleep. So most adults in the UK are chronically sleep deprived. So thinking about that sleep hygiene from our point of view is really important. Thinking about the amount and quality of sleep that you are trying to get and making sure that you do get. Thinking about your own electronic devices and avoiding screens on an evening can be really helpful and can help all of us sleep better and feel a bit better. I will then click on the chat. Sorry, just give me 2 questions. So 2 seconds, sorry. So melatonin. So from we tend to use modified release melatonin for most of our young people that we see. in terms of the advice and guidance, there isn't actually advice and guidance that we are commissioned for it yet. And that's something that needs to be taken up with the ICB. Unfortunately, we would just be overwhelmed because at the minute we get lots of referrals in for sleep, but we just aren't commissioned to see these. We do see certain ones if they meet certain criteria, but a lot of the things, like I said, is actually going back with the sleep basics. And thinking about the sleep hygiene. So sleep hygiene is all those things about the routine, the bedroom, the environment, thinking about what are they doing in that run up to bedtime, thinking about screens, and thinking about avoiding the exercise. So it kind of is all encompassing those areas. Risks with melatonin. Actually, melatonin is a really safe drug. Its side effects are very minimal. We need to be making sure that we're avoiding prescription of suspension in younger children. And actually, it's not licensed in younger children because there's the glycol content within it. From a longer term point of view, there's no significant risks with it that we are aware of. Children and adults have been on melatonin for very long periods of time. We always advocate having a break from it. I often suggest doing that in school holidays because parents don't want to take their children off if they think that it's working, but actually some children don't need it longer term, so it can be stopped. And they can either go down to a lower dose or even come off it because they've actually managed to reset their body clocks. We see that particularly for our teenagers with the delayed sleep-wake phase disorder. They're the ones that really, once they've got it regulated and got it back on track, then that can make it a lot better for them. In adults, yes, so there is a higher risk of cardiac failure. And I think some of the information about that is what's going on from a sleep point of view, and that's difficult to tease out. And someone's asked about delayed sleep be genetic or caused by autism, ADHD. Yes, we see a lot of young people who have autism or ADHD who have either delayed bedtimes, who are struggling to get to sleep. Again, that's one of the indications where melatonin can be considered for use in these young people. And I think if my community colleagues would see that these young people, they often end up having to manage them from a sleep point of view. Richard, you've got your hand up.
Yeah, hi. Can I just ask about you said avoid the solution, melatonin suspension. What's the reason for that?
So it's got glycerol. Sorry, I'm just trying to find a copy of the bears. At the same time, I'm failing to multitask. So it's got glycerol within it. So we need to avoid it in children under the age of 5. I think that becomes really difficult because a lot of parents then say my children can't take tablets. Actually, the tablets are really small, so they can be mixed in with yogurt, and so they can be given that way. We would often advocate having a small tablet. A lot of parents are very reluctant to try the tablets, but actually they find that actually they can hide them and children do manage it. And I think if you look at the formulary itself for the melatonin, it does talk on there about the fact that we shouldn't be giving suspension to under 5s.
Okay, so if they're on our scripts, we might have some of those who are on suspension. We should be doing a search and getting rid of them and swapping those tablets and crushing the tablets.
We should be we should be advocating moving them. It is on there, but it's in the over 5s, so we should be advocating moving them to tablets where we can. Sometimes it's really tricky, and I've had a lot of resistance from parents who've been on suspension for years and not had problems with it. It's actually hugely expensive compared to the tablets, the liquid. It is, I can't remember how many fold increase it is, but it's much more expensive when you look at it.
And essentially it's the same thing as the slushies, the kind of red and blue slushies, is it?
Yeah.
Right, thanks.
I think Julie's got a really interesting question. Why is it so difficult to get a child prescribed melatonin? It's really difficult because I think there is, from a commissioning point of view, where people aren't commissioned to prescribe it. There are certain groups that are, and I think that was the hope with the green top. So moving the melatonin to a plus prescription, that it was going to make things easier. If people are felt to be experts, then they can certainly prescribe it, but it's really tricky. And I think one of the other things with melatonin is, yes, melatonin is great, but people need to do the basics. They need to do the behavioral sleep intervention. They need to do the bedtime routine things. And actually, melatonin isn't a magic fix. It doesn't just work on its own. They need to do this alongside it. And I think that's one of the things that we see really commonly, is that it's just not going to work on its own. Sorry, not to have a more positive note to end on. Yeah, we see parents are buying it. You can get it over the counter in America, in Australia. It's really tricky. Until things are properly commissioned, then unfortunately there's going to be no other kind of way of doing it. For the BEARS screening tool, if you literally Google BEARS and sleep, you can get the, I can't get the link to work, sorry, currently, but there is the link in the PowerPoint slides. And Laura, yeah, BEARS screening tool is a great one to think about sleep from a 0 to 19 service point of view. It certainly helps me remind me what things I'm thinking about in terms of when I'm managing it and things that I'm putting into place for it. Thank you.
Does anybody else have any questions? That was a really interesting session. Thank you, Liz. I'm sure people agree. If anybody's got any questions before we close the session.
I'm now off to a sleep clinic.
A lot of people thanking you in the chat.
And like Laura said, we'll share the slides. I'll just remove the slide with all my children on it, so that they're not shared amongst the Northeast. But yeah, thank you.
Thank you.
Laura, are you happy to remove that slide before it goes out?
Which one is it? Sorry, I'll just
I think it's about the second one in. It's got all my pictures of my children asleep.
Oh, right. Okay, no problem. I will do. I'll stop recording.
Thanks, everyone.
I haven't done that.